Pathology of the lower GI tract. We have ulcerative colitis. It's a chronic disease with acute phases involving mainly adolescents and young adults. We have 420 cases per 100,000 new cases per year. Since it's a lifelong disease, the prevalence in the general population is quite high. Certainly, genetic factors play a role, although they are less relevant than in Crohn's disease. Probably it's the only disease in which smoking is a protective factor. Smokers are less affected than non-smokers. We have macroscopic features like ulcerative colitis involves partially or completely the colon, but it does not affect the ileum. There is homogeneous mucosal involvement. Damaged mucosa appears as ulcerated and lacks the normal epithelium. Remnants of mucosa that has not been destroyed appears as elevations, so pseudopolyps. Differently, Crohn's disease is a segmental disease which may affect the ileum and is characterized by patchy involvement of the mucosa. The macroscopic features of the disease depend on the activity and duration of the disease. The possible presentations are proctitis, so rectum is involved in almost all patients that have not received treatment yet. Proctosigmoiditis and pancolitis, which is the involvement of the entire colon. Inflammation reaches the cecum but it does not pass the ileocecal valve. Ileum is never affected in ulcerative colitis. So ileum is never affected. Usually ulcerative colitis is not treated surgically. Only endoscopic findings are available, not surgical specimens. However, when medical therapy is not able to control the disease, surgery becomes necessary. So we have megatoxic colon. Microscopic features are glandular distortion, which is the most relevant microscopic aspect. Crypts usually are straight and divide by fission. Normally, branching does not occur. In ulcerative colitis, crypts are very irregular and branched. It is a very long process. Cryptitis and cryptabscesses. Cryptitis is the inflammation of glands by neutrophils. Inflammatory infiltrate only in the gland epithelium, not in the lumen of the gland. Cryptabscesses are accumulations of granulocytes inside the lumen of the glands. We have then basal lymphoplasmacytosis. Normally, the bottom of the crypt is immediately above the muscularis mucosae, whereas in IBD, both UCD and CD, there is an increased distance between the muscularis mucosae and the base of the crypts due to the inflammatory infiltrate, plasma cells and lymphocytes. Acute and chronic inflammatory infiltrates, mainly composed of granulocytes, lymphocytes, and some eosinophils. In ulcerative colitis, the inflammatory infiltrate is limited to the mucosa, does not cross the muscularis mucosae. Differently, in Crohn's disease, the inflammation can also be found in the submucosa. We have erosion, so we have it is a loss of surface epithelium. Intact mucosa appears as pseudopolyps. We have mucus depletion. We have lymphoid follicles, especially in the rectum. We have rare solution phases, chronic phases, and no granulomas. They are present only in Crohn's disease. Not all patients with Crohn's disease develop granulomas, but when they are present, they are very suggestive of Crohn's disease. Endoscopy, we have an acute phase, where the mucosa is diffusely altered with few spots of necrosis and hemorrhages. The chronic phase, there is atrophy of the mucosa and the vascularization is reduced. These patients are more prone to the development of adenocarcinoma. The main risk factors are the extension and the duration of the disease. Normally, the precancerous lesions in the colon are polyps. Differently, in ulcerative colitis, the dysplasia is flat. Okay. It's very difficult to detect the mucosal changes at colonoscopy. For this reason, patients undergo endoscopic examination for biopsy every 10 centimeters very frequently. It may also occur more rarely that the preneoplastic lesions are elevated, so it is similar to the usual neoplastic pathway. In the context of ulcerative colitis, they are called dysplasia-associated lesion or masses, DALMA. The evolution of these plastic lesions is quite unpredictable in ulcerative colitis. Until a few years ago, a diagnosis of low-grade dysplasia implied colectomy. Now, endoscopic surveillance is more reliable, so these patients undergo very frequent screening programs. We have also microscopic colitis, which is a peculiar form of colitis. It's called microscopic because the diagnosis is done only by biopsy, so histology. There are two forms. Some people consider both the same entity, others think they're different diseases. We have collagenous colitis, where we have presence of a collagenous band, which is more than 10 micron thick under the surface epithelium, and lymphocytic colitis, where the lymphocyte number is increased. They are more than 20 per 100 erythrocytes. Celiac disease is also characterized by an increased number of lymphocytes in the mucosa, but in that case the cutoff for diagnosis is more than 4 per 100 erythrocytes. It's a common cause of chronic, lasting at least 1 to 2 months, non-bloody diarrhea. For this reason, it has to be considered as possible cause in patients with chronic diarrhea and negative microbiology investigations. The annual incidence is similar to ulcerative colitis, that is 510 per 100,000, but it has the peak of incidence in 60 or 70-year-old individuals. The disease has female predominance. Macroscopic features are at endoscopy. The colonic mucosa is normal, but it's quite fragile. Therefore, one of the major risks is perforation during endoscopy. Microscopic features are, if biopsy is performed, characteristic histopathologic findings are found. We have collagenous colitis, where we have a pinkish area under the surface epithelium, not along the glands, so collagenous band. It contains some necrotic debris and apoptotic cells. There is an increased number of lymphocytes in the epithelium and the glands. We don't know why the collagenous band forms. Probably, as other idiopathic diseases of the colon, it may be an altered response to an inflammatory or infectious stimulus. Sometimes the surface epithelium detaches from the collagenous band. Usually the collagenous band is found homogeneously from the rectum to the cecum, although the thickness in the left colon is decreased. And we have a lymphocytic form where the collagenous band is not present. There are only intraepithelial lymphocytes, granulocytes, and eosinophils may be present. Lab tests are not useful. Both short and long-term therapy with steroids is effective. Budesonide is the drug of choice, only minimally absorbed. Although steroids are able to induce remission in a high number of patients, frequent recurrences occur in case of discontinuation of the therapy. We have diverticulosis, which is defined as an acquired outpouching of the colonic mucosa and submucosa into the pericolonic fat. Diverticulae are usually multiple and occur more frequently in the sigmoid colon. It's rare in people under age 30, but it's frequent in people older than 60. It's a disease of Western population, much less common in Japan and non-industrialized tropical countries, probably because of the dietary differences. Pathogenesis, probably due to an increased intraluminal pressure due to exaggerated peristaltic contractions enhanced by diets low in fiber. The mucosa and submucosa herniates along the small discontinuities created where nerves, arterial, vasa recta, and their connective tissue sheaths penetrate the inner circular muscle coat. Usually they are small, flesh-like outpouching, 0.51 cm in diameter, that occur in a regular distribution alongside the Taenia coli. They can be the site of inflammation, diverticulitis. If the inflammation spread outside, it can cause peridiverticulitis and eventually intestinal perforation and peritonitis. They are usually treated with dietary changes and antibiotics. Sometimes, especially in the case of recurrent diverticulitis or extended inflammation, surgery is required. We have Hirschsprung's disease, which is a motility disorder which affects newborns, one of 5,000 live births. It's due to lack of ganglion cells both in the Meissner submucosal and Auerbach myenteric plexus. In the area where ganglion cells are lacking, coordinated peristaltic contractions are absent, so functional obstruction. It's a functional obstruction. The result is dilatation of the bowel segment proximal to the affected area. In most cases, the aganglionic segment is limited to the rectum and sigma. In familial cases and 15% of sporadic cases, there is a mutation in the RET gene. RET gene is frequently involved both in neoplastic, such as Mann syndrome, and non-neoplastic conditions. The mutations in the RET gene does not allow migration of ganglion cells in the distal part of the GI tract. Mutations in other genes involved in the neurodevelopment occur in at least 50% of cases of Hirschsprung's disease. Diagnosis is based on demonstration of the absence of ganglion cells in the affected segment. It is important to mark the site where biopsies are taken in order to guide the surgeon during the colectomy. The healthy margin for resection is the point where ganglion cells appear to be present. It's not easy to recognize ganglion cells in histology, therefore we use a specific staining, that is acetylcholinesterase staining. Neoplasms of the large bowel. 90% of large bowel tumors are epithelial tumors. Most of them are preceded by a precancerous lesion, so adenoma carcinoma sequence. We have an aberrant crypt, APC mutation is the first event, then we have an adenoma and a carcinoma. The most frequent type of epithelial tumors is adenocarcinoma. Neuroendocrine tumors, although less frequent than in other organs, may also occur. Beside epithelial tumors, the other types are mesenchymal tumors. Adenoma, they are the lesions which precede the development of an adenocarcinoma. Adenoma and adenocarcinoma may also coexist. The microscopic features are overcrowded epithelium. At H&E staining, we have a more blue staining due to increased number of nuclei. They can be classified according to gross features, so elevated, which is the most common, flat or depressed, and the microscopic features, so we have a tubular, a villus, serrated, and serrated. The villus is usually larger than the tubular adenoma, and it may reach very large size, especially when located in the rectum or sigma, up to 10 centimeters. It's a finger-like projection from the normal mucosa into the lumen. Villus adenoma can transform into adenocarcinoma. Sometimes they are removed by endoscopy, and at histologic examination some neoplastic cells are found, sometimes also stromal infiltration. And it is important to decide if the endoscopic removal is sufficient or if the patient requires a surgical resection. There are criteria based on the grading, the depth of infiltration, the vascular invasion, and the margins that allow stratification of these patients. We have serrated, so hyperplastic, or traditional, which is less frequent. It's called traditional because it was described many years before the sessile adenoma. And the sessile, which is more difficult to be recognized for two reasons. They are usually flat, and there is no sharp demarcation between normal mucosa and adenoma. They have a high frequency of neoplastic transformation. We have then adenocarcinoma. At histology, they are divided in different grades, G1 to G3, according to the morphologic differences between the neoplastic cells and the normal mucosa, presence and differentiation level of glands. Some histopathologic and molecular features are relevant for prognosis and therapy. TNM. If the tumor is confined to the lamina propria, there is almost no chance to have lymph nodes metastasis. It is considered as a carcinoma in situ. If it invades the submucosa, the chance to have metastasis is quite low, but it exists. There is a progressive increase in the risk of metastasis as the tumor extension increases, so have muscularis propria, subserosa, and peritoneum. If the tumor invades the surface of the peritoneum or other abdominal organs, it is called PT4. We have then vascular invasion and budding. It is the extension of the tumor by single cells in the surrounding stroma. It's the reminiscence of the epithelial to mesenchymal transition. The plastic cells acquire motility like mesenchymal cells to infiltrate the stroma and reach the vessels to metastatize. High number of these cells at the margin of the tumor is a negative prognostic factor. Inflammatory and stromal reaction. The presence of an inflammatory reaction is a positive prognostic factor. So, if we have inflammation, it's a positive prognostic factor, while high number of these cells at the margin of the tumor is a negative prognostic factor. Molecular assays. We have KRAS, NRAS, and BRAF mutation, which are relevant in the selection of patients for anti-EGFR therapy. It's one of the main treatments available for metastatic colorectal cancer. The result of these mutations are constitutionally active proteins. You have microsatellite instability. Patients with tumors with microsatellite instability have different prognosis and different responses to therapy, especially to 5-FU. And then we have PTEN analysis. KRAS and BRAF are signaling molecules of the AGFR pathway, which is usually constitutionally active in colorectal cancer. Therefore, it's a good target for drugs, anti-AGFR therapy. However, if the tumor carries mutations in KRAS and BRAF, they are constitutionally active. Their activation does not depend on AGFR signal, and anti-AGFR becomes useless. Since anti-AGFR therapy is very expensive, 6 months of therapy cost about 40,000 euro, it's very important to select patients that can benefit from it. These three genes, KRAS, BRAF, and NRAS, share signal structure. They are GDP binding proteins. Mutations usually occur in amino acid residues of the catalytic domain. So, key points are: when RAS is mutated, it's constitutionally active, and patients with KRAS, BRAF, and RAS mutations do not respond to anti-AGFR therapy. These lesions, KRAS BRAF mutations, are frequent events in colorectal cancer, 40%. Other genes are relevant in colorectal carcinoma. The most relevant is APC. When APC mutation is in the germline mutation, it's responsible for the familial adenomatous polyposis. This syndrome represents less than 0.5% of colorectal cancers. Alterations in genes of repair mismatch system, which result in microsatellite instability, are responsible for HNPCC, hereditary non-polyposis colorectal cancer, also called Lynch syndrome. This syndrome represents 2-3% of colorectal cancers. Alterations similar to those that are found in these two genetic syndromes, APC and mismatch repair system mutations, are present in the two major groups of colorectal cancers. In fact, 5% of all colorectal cancers have some genetic problems. Among these, only 15-30% have a major hereditary component, FAP and HNPCC. Two major groups of colorectal cancers are microsatellite stable, chromosomally unstable, non-hypermutated, which is 75% of colorectal cancers, a relatively low number of oncogenes and tumor suppressor genes, most prominently APC, KRAS, and P53 are mutated. The typical clinical presentation is it occurs more frequently, 80%, in the left colon and has male predominance. Rarely they are mucinous tumors and with very few intratumoral lymphocytes, budding and frequent necrosis. Have precancerous lesion, so villous adenoma. Then we have the other group, which is microsatellite unstable, CpG island methylator phenotype, CIMP, and hypermutated, which makes 25% of all colorectal cancers. The frequency of mutations is much higher. Mutations in mismatch repair system, MHS1 and 2, are the proteins most commonly involved. Typical clinical presentation is these patients are younger and there is female prevalence. They typically occur in the right colon. Although these tumors respond less to 5-FU, these patients have a better prognosis. The precancerous lesion is a sessile serrated adenoma. The germline and somatic mutations tend to occur in different regions of the APC gene. APC gene, so the first group, the microsatellite stable, chromosomally unstable, non-hypermutated. APC gene is linked to the control of the Wnt pathway, which results in control of beta-catenin. APC mutation has to occur in a stem cell, which expresses LRP5, which is a molecule involved in the Wnt signaling, in order to cause the development of an adenoma or adenocarcinoma. If APC mutation is introduced in a differentiated cell, adenocarcinoma will not develop. There is a progressive accumulation of cells with this mutation that are unable to differentiate and form an adenoma. Alteration in ACP results in problems with beta-catenin, which is not phosphorylated and not degraded. It accumulates, translocates into the nucleus and works as an oncogene. In normal cells, beta-catenin is on the membrane, whereas in APC mutated cells it accumulates in the cytoplasm and in the nucleus. Recently, other mutations in this pathway have been discovered. Second, which is the microsatellite unstable CpG island methylator phenotype hypermutated. These tumors carry microsatellite instability, which is a sign of defects in DNA mismatch repair system. The two main proteins involved are MSH1 and MSH2. Healthy cells produce MSH1 and MSH2. Whenever there is a defect in the genes, no proteins are produced. This is what occurs in neoplastic cells, which in fact are negative if stained for these proteins. There are sporadic forms, which are more common, and the genetic germline form HNPCC, aka Lynch syndrome. Always consider the patient's history. Other cases of colorectal cancer in the family, especially in the rectal colon, in order to classify the tumor as sporadic or familial. Analysis of BRAF gene may help in the distinction. In Lynch syndrome, the tumor frequently carries KRAS mutation, while sporadic cases carry BRAF mutation. These patients have synchronous and metachronous tumors, especially extracolic tumor, endometrial, gastric, and thyroid tumors. They produce mucin and are characterized by intraepithelial lymphocytes, CD8 positive infiltration. The infiltration is sign of effective immunological response. MSH1 phenotype. It's prone to acquire mutations in microsatellite repeat tracts, and these mutations can inactivate tumor suppressor genes or activate oncogenes. These genes are different from the genes involved in microsatellite stable tumors, which have, for example, APC mutation. So the key point is most of the tumors in the right colon have mutations in the mismatch repair system, MSH1 and MSH2, while non-hypermutated tumors, which usually occur in the left transverse colon, carry APC mutation. So normal inactivation of APC, dysplastic crypt, mutation of KRAS, adenomatous lesion, SIM defect, 18q loss, inactivation of p53, and carcinoma, development of carcinoma. Otherwise, there is the second way. Anyway, for a long time, villus adenomas have been considered benign lesions. In reality, most of them carry APC mutation and are precancerous lesions with low potential to evolve. By removing a villus or tubular adenoma, you reduce the risk to develop an adenocarcinoma. On the other hand, sessile serrated adenoma with dysplasia carry a high potential of evolution. Most of them are methylated in MSH1, frequently in BRAF, no KRAS mutation present in HNPCC. They are more difficult to be recognized, grossly they're similar to altimucosa, and treated with respect to traditional adenoma. So more difficult to be recognized and treated with respect to traditional adenoma, which is villus. Control of this type of progression, so sessile serrated adenoma to adenocarcinoma, is much more difficult because the neoplastic lesions are more difficult to be recognized, and we don't know yet the timing of evolution of this type of lesions. Probably it's much more rapid.